Good afternoon, everyone. Dean Madeleine Sosa, APMC President, Dr. Rosario Bernardo Lazaro, PASCOM President, beloved medical school deans, faculty and participants, colleagues and friends. This seminar on primary healthcare is a priority program, a centerpiece program of our APMC President, Dean Madeleine Grace Sosa of the De La Salle Medical and Health Sciences Institute. This academic exercise is being conducted in coordination with the PASCOM, Philippine Academic Society of Community Medicine, led by its president, Dr. Rosario Bernardo Lazaro of the Ateneo School of Medicine and Public Health. Assisting in this valuable project is the APMC Curriculum Committee, led by Dr. Remedios B. Chan, Assistant Dean of the Faculty of Medicine and Surgery of the Pontifical and Royal University of Santo Tomas, the Catholic University of the Philippines. I hope I got that right. As you know, the Universal Healthcare Law specifies that the main strategy of care should be primary health care. The main task, therefore, of this seminar workshop is to help each other develop, model instructional design in reorienting the medical curriculum to primary health care, whether your school curriculum is discipline-based, competency-based, problem-based, integrated, community-based, or other curriculum types, as long as the outcomes are clearly stated. I am not a stranger to primary health care, so let me set the tone of this seminar by relating to you some local historical footnotes on primary health care. Let me name some giants of primary health care. Juan Flavier, in his Philippine rural reconstruction movement, all his achievements and stories are documented in his books, Doctor to the Barrios. Mundo's Marinduque Community Project under the Far Eastern University, Dr. Nicanor Reyes Medical Foundation. Florentino Solon's Pacnaan Community and Nutrition Program in Cebu under the Cebu Institute of Medicine. Paulo Campos Comprehensive Community Health Program, or CCHP, at Bae Laguna under the University of the Philippines. This is where I first experienced working in a primary healthcare setting as a rotating PGH intern and later as a pediatric resident. We rendered health care to the rural poor, farmers and fisher folks in Bae Laguna. Later, as the chair of the newly created Department of Family Medicine, we organized the first primary healthcare program financed by the Philippine General Hospital in Angono, Rizal, the hometown of the national artist Carlos Botong Francisco. Consultants were never absent in the weekly community conference in Angono. It included a tour of the house and gallery of Botong Francisco, as well as the houses and galleries of his pupils and disciples. The rotating interns, residents, and faculty lived in the Angono community. After about 5 or 6 years, the program transferred to Muntinlupa, Rizal. But lo and behold, one day the whole staff, interns, residents, faculty, nurse, and staff arrived in our PGH office carrying their belongings. They were kicked out of the town due to a conflict of the program objectives and the desires of the local executive. The lesson learned here was that you must court the local leadership in order to succeed. The easiest and fastest way to transfer the program was to conduct it at home base, and that means at the University of the Philippines Diliman campus, where there was a big population of informal settlers. The students were now rendering healthcare to the urban poor, a population with a totally different social and health needs. During my term as Dean and then Chancellor, a good 12 years, the program was conducted in Batangas. This time, the local governments were courting us because of our track record. First, we were in Laurel, the farthest town, then in Santo Tomas, and finally in San Juan, Batangas, the site of the popular La Ia Beach Resort. Of course, the interns and staff loved the place. After public health work all day, they went swimming. They enjoyed swimming at the beach. The young men and women of the town enjoyed watching them. The senior people was expectedly scandalized because the female doctors were wearing two-piece bathing suits, and this they expressed in writing. And this was easily remedied, of course, but we did not issue a no swimming memo. We issued a request that the ladies please wear a one-piece bathing suit instead. The program in Batangas was renamed Community Health Development Program, or CHDP. It became the venue, the primary healthcare training community of the health science colleges in UP Manila, nursing, pharmacy, physical and occupational therapy, and others. Here they learn interprofessional work and communication. Our next experience with primary health care was at the National Capital Region. That was before the creation of the MMDA, or the Metro Manila Development Authority. A 6-point program was organized in Metro Manila as an experiment. The first strategy was the Go to Your Health Center program. At that time, the patient population was hospital-oriented. Primary healthcare patients preferred to consult at the hospital OPD clinics rather than in the health centers. They did not have much trust and confidence in the health center services. So we scheduled all health center physicians in the 14 local governments within Metro Manila to take a crash course in ambulatory care and gave them a training certificate of having attended a training course in PGH. This they proudly hung in the walls of their health centers. At the hospital OPD, we introduced the triage clinic. Primary care patients were given 10 minutes of care and 15 minutes of health education, emphasizing the importance and capability of health center physician care. They, they were given they were given a referral to the health center assigned to their barangay. With these two strategies, we successfully relocated the venue of the proper care of the primary health care patients, which is the health center. A second strategy was the human resource development, where the nurses, midwives, and other healthcare workers were given a retraining. A, a third strategy was the maximum utilization of existing resources. There were only about 100 health centers in the 14 local governments in NCR. The puericulture centers, which were private and semi-private, were invited to join the health center network in the NCR. Maximum utilization of medical manpower was also practiced. For example, Quezon City had so many doctors, and Marikina only had a handful of doctors. The Quezon City Health Department was requested to share their doctors to doctorless health centers in Marikina. Hospitals too were asked to join the hospital network of Metro Manila, including hospitals that were under other national government agencies. At that time, the government allotted more than sufficient funds for service and research in two areas: family planning and nutrition. And so a fourth strategy concentrated on child health and nutrition, and a fifth strategy attended to maternal health and family planning. The sixth strategy in the 6-point program was disease prevention and health promotion. These areas were attended to by the departments of family medicine, community medicine, and preventive medicine. In addition, an interagency referral system was organized. There was a networking among barangays, health centers, and hospitals. A couple of barangays were assigned as the catchment area for a definite health center. A couple of health centers were assigned as catchment area for a secondary hospital. And secondary hospitals were assigned to a referral tertiary hospital. The approval of the healthcare law is a welcome move. It is the expression of the political will of our national government to improve the delivery of healthcare. Primary healthcare is the main strategy. The CHED, or the Commission on Higher Education, can issue an order directing medical schools to integrate primary health care in the curriculum using the outcome-based education strategy, or the OBE strategy. However, the medical schools have the academic freedom to decide how to teach primary health care according to the curriculum of their individual school, whether it's discipline-based, competency-based, problem-based, integrated, or community-based. Primary health care involves all clinical departments, not only the departments of family medicine, community medicine, and preventive medicine. So let me therefore end here. I hope you enjoy the rest of the workshop. Thank you.